Before I start, for those who just joined, welcome. I assume you can hear me okay? Someone gives a thumbs up would be good. Fantastic. Hi everyone, my name is Bennie. I am the CEO of AMA Western Australia. Welcome to our webinar tonight, the reforms to sex or gender recognition in WA. This is an information session for doctors, but in fact also good for psychologists in this reform process, which has commenced already 3 months ago. And I would just like to start the session by acknowledging the Aboriginal peoples of the many traditional lands and language groups across Western Australia and their connection to land, water and community. We pay our respects to them and their cultures and to elders past, present and emerging. Today's webinar is 1 hour long and it will be recorded and it will be available to participants and other GPs who request a little bit later. The order for tonight is going to be pretty swift. We are very lucky tonight to have a panel of experts and policy people who have been developing this process and this scheme, and they will be here for the panel session a little bit later. But we're going to start with Tatijana Vukic from the Department of Justice, who give us a background and a summary of the administrative process. Then we are joined by Dr. Mary Wyatt, who's the chair of the General Practice Group here at AMA Western Australia from the clinical perspective. Then we're going to have a panel of 5 experts. So in addition to Tatijana and Mary, we're going to be joined by Alison Jackson, who's the Registrar of the Registry of Births, Deaths and Marriages, Liz Perkins, who's the Principal Policy Officer at the Department of Justice, and for legal and medical legal questions, we're very lucky tonight to have Catherine Elphick, who's a legal advisor from Dominion Legal. So without further ado, I am going to ask Tatijana Vukic, the Project Director Implementation from the Department of Justice, to kick us off on the background and summary of the change.
Thanks, Dr. for the kind introduction, and thanks everyone for being here tonight to talk about these important reforms. My name's Tatijana and I was involved in the implementation of these reforms by the Department of Justice in partnership with our Department of Health colleagues. I'll kick off the session by explaining the rationale for the reforms and how the new process works, just to provide a little bit of context for the rest of the session. Feel free to ask questions as I go. If you have anything burning you kind of want to ask right away, or please just keep track of what you want to ask and we can bring it up with the panel at the Q&A session. So the reforms to sex or gender recognition commenced on 30th of May this year, as Bennie mentioned. Prior to 30 May, WA was the only Australian jurisdiction where a board determined a person's application to update their sex or gender in their birth record. So via the previous process, a person who had undergone a medical or surgical reassignment procedure was able to apply to a board for a recognition certificate of their updated gender. This certificate could then be presented to the Registrar of Births, Deaths and Marriages, who was then required to register the updated gender in the certificate. In 2018, in a report called Report on Project 108, the Law Reform Commission of WA recommended that the board be abolished and that an administrative process to update sex or gender via the Registry of Births, Deaths and Marriages be established. The reforms to sex or gender recognition essentially gives effect to these recommendations. So the reforms streamline the process for gender recognition for trans and gender diverse Western Australians, and they remove the outdated barriers that make it difficult for people to obtain identity documents that align with their lived identity. Next slide, please, Natalie. So I'll just give you a little summary of how the process works at a really high level. Under the new process, adults can apply directly to the registry to update their sex or gender in their birth registration. And they can do this if their birth was registered in WA and they believe that their sex or gender is the one they've specified in their application. The application requires 4 key things. So firstly, it has to be in the approved form, which is on the registry's website. Secondly, it has to specify a sex or gender classification prescribed in the regulations, which are male, female, and non-binary. Thirdly, and probably what is most interesting to the group here tonight, is that it has to be accompanied by a statement from a doctor or a psychologist certifying that the person has received appropriate clinical treatment in relation to their sex or gender. Dr. Wyatt will speak to this requirement a bit later on from the perspective of a highly experienced medical practitioner. And finally, the person has to declare if they are a required declarant. And this term is defined in the legislation and includes people who are high-risk serious offenders, detainees, prisoners, reportable offenders, and supervised offenders. The registrar can then make the requested update unless the person's sex or gender has already been updated in the past 12 months or 3 or more times in total. A person can then seek State Administrative Tribunal of the registrar's decision if they feel aggrieved by it. Next slide, please. So the process is a little bit different for young people depending on whether their parents support the application and their age. If a young person is over 12 years of age and both parents support the application, the process is very similar to that of adults and the application can be made directly to the registrar. The key differences are that the young person has to also provide a statement of consent to the update to their sex or gender, and that the parents must each believe that the young person's sex or gender is the one specified in the application. If the person is over 12 and only one parent supports the application, or the child is under 12 years of age, the parent or the parents have to then apply to the family court for an order approving an update to the child's sex or gender in their birth registration. The parent or parents can then submit an application to the registry, which has to include the family court order. And in these circumstances, the registrar has to make the change in line with the order, and there's no real discretion here at all. If the young person is over 12 years of age, but neither parent supports the application, the young person themselves can apply to the family court for an order and then apply to the registry that way. Next slide, please. For people born outside of Australia, the application process pretty much mirrors the processes I've just spoken about for adults and young people. However, people born outside of Australia will receive an acknowledgement document acknowledging their updated sex or gender. They won't be able to have their WA birth registration updated because their birth isn't registered in our state. People born in other Australian jurisdictions should apply to update their sex or gender in their birth jurisdiction. Next slide, please. So doctors and psychologists play a really important role in this new administrative process, which is what the majority of today's session will be about. As I mentioned earlier, a person's application has to include a statement from a doctor or psychologist certifying that the person has received appropriate clinical treatment in relation to their sex or gender. Importantly, a person isn't required to have undergone a medical or surgical reassignment procedure to be able to apply to the registry anymore. I won't talk any more on this topic because I think Dr. Wyatt is the person to give you this information. And I think from the perspective of a medical practitioner rather than a policy person sitting at the Department of Justice. So that's all for me. Thanks for listening, and over to yourself, Mary.
Thanks, Tatijana. Just so for people who don't know me, I'm a GP. I work in a general practice in Perth Central, and I do a lot of work in the LGBTQI community with informed consent. So I feel like I can speak to this topic. So if you can work to our next slide. Do I have control? Yes, thank you. So it's very similar to what you wrote, Tatijana. So the most important thing is that as doctors, what we need to do is provide a statement to our patients. And there are quite a few, there's some guidelines on the website. If you go to the Justice Department's website for information, there are some sample letters that you can integrate into your software to create this letter quite easily. But another important point about this is that the legislation doesn't require the doctor or the psychologist who's actually writing the letter to be the person who has prescribed the treatment. But they do need to be aware of the treatment that our patients have received. So if you can slide across to the next one. Yeah, as Tatijana said, in the legislation, there's actually no definition as to what is appropriate clinical treatment. And the decision as to what is appropriate is actually a decision that you can make as a medical practitioner or a psychologist based on what our medical standards are and our clinical judgment. And we know our patients quite well and often form a very good relationship with them. So we will know that they're actually, this is the life that they are living, and the gender or sex that they would like to be known as is the one that they're applying for. It's important to know there's no minimum requirement for treatment. And in fact, you may actually see patients coming in right very early on in their journey or further along in their journey of gender affirmation. And what our patients receive, they will be maybe very different for many different people. For instance, I have quite a few non-binary patients, and for them it's how they live, and sometimes it's about their pronouns, making sure that they're they them, and then others who are trans woman or a trans male, who have actually started to go through the gender affirmation hormone treatment. But it's really a decision between your clinical decision that you make and with your patient as well as to what is actually appropriate for them. If we go to the next slide. So what is appropriate clinical treatment? And because it's not defined, it can be so many things. The obvious one is when we have patients who come to us for informed consent and they've started on hormone therapy. It could be a young person who's on puberty blockers. It could be just what physical changes that a patient will do to be seen as their identity. So, chest binders, they may be going to speech therapy, trying to modulate their voice to be more feminine or more masculine. They may be going and having some facial hair removal or body hair removal even, so that there's very little body hair. Or they may be just talking to a psychologist about their gender and what that means for them. So there are many, many different ways that our patients come to us, and that's clinically appropriate treatment. And what is also important is that you as a doctor and in discussion with the patient may actually decide that, as I said earlier, there's no actual treatment as such that's required, other than that when the patient identifies a certain way and they wish to be not misgendered, so they're female, they're male, they're non-binary, it actually causes them quite a lot of distress when we write their pathology forms or other information and they actually see the wrong gender written up. So it really is in between. It's a clinical decision that you will make with your patient and to work out what is clinically appropriate. So it's quite wide and varied. And I think the most important thing is to actually be open to this as well. Next slide, please. So I'm on my last slide here too, by the way. In all circumstances, this is really, really important as well for us to know as doctors that this document that we are creating with our patients, it doesn't need to specify at all what the treatment is. So that treatment that we're undergoing, or our patient is undergoing with us, it's in confidence. It's a doctor-patient confidentiality. So it's just a very, very simple statement that they've had clinically appropriate treatment. And I wanted to reiterate this most important point, that your patients may be at different stages in their gender affirmation journey. And the first step for them may be that they wish to change their gender or sex identity legally before they actually go through with any more invasive treatments like gender affirmation hormone therapy, top surgery, bottom surgery, etc. And that when we meet our patients, just to be very open to this. Hopefully that explains. It's a wide area. I think at the end of the day, it's actually about being open to the fact that this is a very important part of the journey that our patients are going through to actually have their correct lived gender or sex identity on their documents. And I think we are now up to the panel. Is that right?
Fantastic. Thank you, Mary, and thank you, Tatijana, for that intro background and a succinct summary from a clinical perspective. Now, as you know from the promotion, this is supposed to be interactive, and I note that we've got a few of you joined online. If you want to ask a question, please put your hands up on Teams, and I'm very happy to throw the mic to you. And you're also most welcome to type the question in, and then I will read it out. But as I said, we've got an expert panel. I have called the names out earlier, so I probably won't repeat the same, but I'm pretty sure we can handle most of the questions that you've got. Given the scheme has started 3 months ago, perhaps what I'll start is throw it to Alison Jackson, who's a registrar at the Registry. What's the numbers like? How many people have gone through this particular process in the last 3 months? Alison, can you shed some light, please?
I certainly can. We're, as you said, just shy of 3 months, and as of yesterday, we had processed 132 applications. The vast majority of those are for WA-born adults, 117. So the rest, some overseas, a few children, but yeah, we're a little bit surprised by the numbers. We're actually expecting more, and we're starting to see a bit of a drop off already in the applications coming through. We're, I guess, a bit worried about whether or not we're going to be able to manage the volumes, but thankfully it's gone fairly smoothly. So we're pushing through them pretty quickly.
Thanks for that, Alison. So in terms of the form side of things, have you or your team experienced anything that in terms of the letters or from an admin process that I guess would help in terms of giving tips to some of the doctors around, or have they been doing it so well that they just need to keep going?
We've had a few supporting letters coming through from medical practitioners where they have detailed the treatment that the applicant's undertaken, and it's quite detailed, and obviously from our perspective quite personal and private information. So all I would say is that yeah, we would just urge practitioners, if possible, just to clarify or just to confirm that the person's had that appropriate clinical treatment, but they certainly don't need to be describing that in the letters. But otherwise, yeah, the support that we've got already and the support that our applicants have had has been tremendous. So.
There's a lot of information on the website for those who are not aware, and we do have links at the back of the slide pack that we are happy to share later. Some of those information, the group here, including AMAWA, we've been providing advice to make sure that it is relevant and easy for the doctors or psychologists to submit the information. But as Alison said, it sounds like that some people probably are erring on, more to prove themselves than what's actually required. But if you need to get that information, please just check the website. I think it is very easily accessible. In terms of, I don't know whether you're allowed to share, Alison, doctors and psychologists, what's the numbers like from in terms of a split? Are you allowed to share, or I'm asking a little bit too
No,
in-depth
that's
of the
fine.
question?
Anecdotally, and I have to admit that I don't see a lot of the applications myself.
Right.
I would suggest that it's more general practitioners than psychologists that we're getting the support letters from at the moment.
Yeah. And I suspect Mary's probably done a few, but I won't ask you how many you've done, Mary. Just a reminder, if anyone's got any question, please feel free to put your hand up and I'll call you guys for your questions. Nothing is too silly to ask in these type of forums, because everything is there's quite a lot of new things here, and the purpose of this is to have you informed of what's going on, and anything that you want to ask, please put your hands up. Maybe I will just go on to a question that, maybe GPs who haven't done these before, but are GPs expected to go through the meaning and the implication of the change of sex or gender application? What do the panelists, I guess there's two angles here, in terms of what's a minimum that, is envisaged, but from a medical legal perspective, are there things that, the doctors or psychologists should cover off? I'll leave it to you guys to pick who wants to start first.
Well, I guess I can say that in terms of what was put in the legislation. So essentially, when we were developing the legislation, there was a concern that we were asking for the child's consent to the application, but there was no assessment of whether the child had the capacity to consent. So essentially what we're asking through that, because it's for children only, is just a verification that the child has the capacity to consent to the application, and then effectively, not being forced in a direction that perhaps they don't really understand what's happening.
Yeah, I was just going to add to that. I think it's when you're dealing with those children, they're the only ones, I think, where the doctor has to sign off saying that they do have an understanding. So I think it's important for the GPs when you're dealing with kids in that certain bracket. If you go back to that slide, it was set out really beautifully. But yeah, when you've got the kids, you need to go through with them and assess whether you feel comfortable that they understand maybe what the implications are or what it is that they're actually doing.
And I'd probably just add from the adults, so I've done quite a few adult letters, that they're coming in very well informed. And I probably would only be concerned if someone has changed their gender a couple of times, that I would be my job then to say, this could be your last time because you're on your third. The only thought I've had where something like that could happen, and I haven't really explored it properly, is if a patient is a trans male and wants to have a hysterectomy, this is something that hasn't been quite cleared up, whether they can still get a hysterectomy with their birth gender male. So that may be a situation where you might see that occurring, but I don't know if that's necessarily going to be something that I'd be counselling all of my patients about, but I may mention it just to make sure that they are aware.
Mary, you touched on the fact that the patients that you have seen are well informed. Can you give the audience how they usually present from your perspective? And I guess on the other side, if you don't see a lot of these patients, what kind of signals or should you kind of pick up to make sure that the conversation is appropriate and that the patient will be managed appropriately?
So I think the first thing that I always notice, and it's with a new patient, is their pronouns, and that's something that I mean, I see a lot of new patients who specifically come to see me because they want to start on hormones. But I've had a lot of non-binary patients the same way, coming in and changing their pronouns. So I think it's just being aware of that in the first place, and then also making sure too that you're calling them by their right name. And that then starts that conversation about over time as to whether they're ready to change their gender or sex on their birth certificate and with Medicare. So that's why I mean they're quite well informed by the time they see me. They've actually sought me out. They've been on groups. They're well connected socially. And it's also not for a lot of patients. I haven't met really anyone who's been spur of the moment. And if they are spur of the moment, they're really just never for a gender change letter. But they're really at the beginning part of their journey. So it's just allowing them time to work that out and where they want to go with their clinical treatment. I noticed that Belinda put a note up on the chat as well, just about how easy it is for us as GPs to do this, and using that template really makes it quite easy. So I don't know if that's something that, if you're not aware of that, going and looking at the website, our patients do that. They actually, if they haven't directed you to it, they will direct you to the website I think it's on the Justice site, and it's really well documented what they need to do, the letters they need to do, the letters that we need to do, the steps, and they've come in already quite informed about it. And I was very pleased when the legislation came through, because some of them were wanting these letters before it came through, and I actually didn't know what I needed to write. So it's helpful.
Belinda, I don't know whether you want to make any comments. I suspect you've got quite a few patients who may come through your clinic too, but feel free to speak up if you want to, and I hope you heard what Mary said. And I think Tatijana has just posted the template as well. So
Belinda's having some technical difficulties with her microphone, but I have popped the link up for both the template statements and just general guidance material, which the Department of Justice, the Department of Health, developed in collaboration with AMAWA and other professional medical bodies as well. So we sought feedback from various groups just to make sure that all of the guidance and templates we've issued, Alison has issued through her website, are actually going to be helpful to you guys, and that we've tried to keep them as less governmenty as possible, so that they're as easy to understand as possible.
Thank you, Belinda, for your comment, even though we can't get the voice to work. But yeah, we are trying to, in fact, get the message out there. And I guess it's that's why we're very happy to partner with the government to do these type of very important information sessions. And just to go back on one of the earlier question about, you know, some of the doctors write a lot more kind of the clinical or personal information onto the form. Can I just check on the privacy side? I suspect some of the patients do have that worry, but who has access to the information provided when they submit it, and how confidential are they, where they kept, etc.
I'll take this one if that's okay. The letters and the application come through to the registry in a couple of different ways. Sometimes the applicants come into the registry and speak to someone at the counter, or sometimes they come in by post. But either way, the applications are scanned and captured into the WA registration system, which is our register, basically. Once they're in there, it's just staff and a very limited number of people around the state that have access to that information. And also, just for future access or future information release, we're very restricted, as we should be under the Act now, with regard to who we can release this information to, and particularly previous sex and gender history. So I would see, particularly for the letters that are coming through from medical practitioners and clinical psychologists, once they go into the system, from my perspective, there is no reason to previous sex and gender history. So I would see, particularly for the letters that are coming through from medical practitioners and clinical psychologists, once they go into the system, from my perspective, there is no reason to be releasing them to anyone, except in the situation where I was summoned or subpoenaed or compelled to do so for a court matter or a tribunal matter. So once they're in there, they remain in our database, which is very heavily fortified, as it should be, because it's holding the state's life event data. So very, very restricted, particularly with sex gender information now.
Alison, can I ask a question? How long does it take to process? So how long could a patient expect that process to take before their birth certificate is changed?
When we first kicked off, we just didn't know what the volumes were going to be. So we put up on our website to please be patient and say, give us, I think it was 4 to 6 weeks. Mm-hmm. But I think we're, I can't believe I'm going to say this, but we're up to date entirely with our workloads at the moment. So we're generally pushing through within a couple of days of receiving the application. So
yeah, that's amazing.
Yeah. I can't guarantee that that's going to be like that in the future, because it's just might be the case that all the planets have currently aligned here at the registry, but yeah, pushing through them really quickly. And it's actually, it's probably a cumbersome process still for people that are applying. They've got to push their way through the form, but it's not that complicated, the process. Once we've checked, gone through a bit of a checklist to update the register and then print out a new certificate for them if that's what they would like. So
yeah, wow, great.
Panel members, there might be doctors who don't feel comfortable to provide the statements. Just want to see whether there is a legal requirement when a patient turns up, and whether a doctor or a psychologist is compelled to do so.
I can answer this one, Benny. So the legislation doesn't impose any mandatory obligation on doctors or psychologists to provide a statement. So if a doctor or psychologist doesn't want to provide a statement, they can refer the patient to someone else who can help the patient. So the reforms don't introduce any kind of obligations on medical practitioners in that respect.
And I think, you know, just good patient care. If someone came to you with a request that you didn't feel comfortable with, you'd acknowledge the request really respectfully, and you might just say, that's not something I do, but you know what, I'm going to put you in touch with my colleague who does. And you know, I think that's acceptable. I don't think anyone would have any difficulties with that. So it's about managing that so that you minimize the chance of a complaint, but just doing it in that respectful manner, much as you would with any other medical treatment that you weren't comfortable with providing.
Mary, have you? Oh, sorry, Benny. I was just gonna ask, Mary, have you found people being referred to you by other practitioners?
Not for gender change, but certainly for informed consent. So, and I'd be the same for Belinda and those of us who are known to do that. But yeah, I mean, I've had in my practice, I've got doctors who don't do it, the informed consent process, but they've been happy to write the gender, gender letter. I'm calling it a gender change letter at work. It's probably the wrong word, but that's what I've popped it in my VP software as. But yeah.
Is there well, what if you're a doctor who don't know who else referred to? Is there a particular place that has a list of doctors that do these at the moment, or would you? How does that work?
I think you're talking about oh gosh, I've forgotten the word, but basically gender-friendly doctors, I suppose you want, if you want to, for a word better name, trans folk, WA, and a lot of our patients have already started researching that, and in there's a list of doctors who are already, you know, trans-friendly, and so they're probably the doctors that will probably do most of this, but most of us will still have patients, I know, in a practice where, trans folk, sorry, have the GP list, so I said that wrong. But most of us will have patients who we just know and that are getting treatment maybe with an endocrinologist or someone else, and you may not actively be doing that treatment. You if you felt comfortable, could write that letter, and I think that's one of the most important points to get across to GPs, that you don't necessarily have to be the person helping to provide the gender affirming care, hormones, whatever it is. But if they're your patient in lots of other ways, they're one of your diabetic patients and they're known to be a trans patient, that you can write that letter for them. Yeah. But their patients, they're quite well informed. They definitely, I think, probably one of the most well-informed groups of patients that I've ever met, actually.
That's very useful. So I guess they'll know where to seek the information and probably find a friendly doctor, as you said. I just noted, Natalie, that the recording stopped about 6 minutes ago. I don't know whether it needs to be restarted, but it's better a transcript on the side. I am so medical legally. I'll go back to that, Catherine. Is there something that the doctor has to declare more in their renewal process? You know, I guess this started in May, and whether some of the MDOs have done a July changeover, but Is there something that the doctors or the doctors, I don't know whether I can speak for psychologists, but that they have to worry about in terms of legal repercussions?
Look, I think in terms of legal repercussions, I would think this is at the really, really low end of the spectrum. Everyone gets worried, well, what if I do this and someone changes their mind? Is this going to come back and bite me? I don't think anything like that would occur. I think if you're practicing good practice anyway, what I would encourage everyone to do is to keep really good notes. And, just in your own mind, you need to be able, you think, well, if someone came to me and said, why did I write this? I need to be able to justify that. So document the conversation that you have with people, collect, if there is the endocrinologist, if there is the pediatrician, if they are providing that input, make sure you keep all those notes. I think there's a risk maybe with someone that you've never met before. And I think maybe, Mary, you said, that person who comes in, you've met them only once. Maybe I would encourage them, look, we'll have a chat now, come back again next time, because, I want to hear more about this. And because it's very hard with someone that you've never met, if they're just walking in off the street and they tell you these things and you're thinking, might be true, but I don't know. And I don't think there's anything wrong, and maybe, Mary, you might have a different point of view, but I don't think there's anything wrong with starting that conversation and saying, look, yeah, are you okay with me talking with your other specialists, collecting all that kind of stuff? Because as a practitioner, you need to be able to justify that. And, sometimes you may be subpoenaed, you may be called down to SAT if it's a child, or there may be, family court hearings. So you want to be able to go back and have really good records. I think if you're doing this in good faith and you can satisfy yourself, I think there's a really, really low risk attached to that. It's a certification only. You're not, as you said before, you're not saying I provided that treatment. You're not necessarily, verifying the gender that's been selected. There's none of those kind of things. It is almost administrative in some sense. So I think in terms of premiums, I would have thought it's not that high risk kind of practice that might mean you've got an elevated premium because you're dealing in something which is high risk.
That's very reassuring. Thanks for that. It's the less barrier, I think, the better, especially for the patients. Can I don't know whether anyone else has got the legal repercussions side of things. Mary, do you have any comments while you're practicing the note-taking part? Clearly, that's very important.
Well, I document everything. And, when I'm doing a diagnosis of gender dysphoria and informed consent, that's, I think, really important. But I would agree that it'd be very rare for someone to walk off the street straight up, new patient, to say, I want a letter, I'm going to change my gender, without actually having had a conversation with me, with at least one consult, where we can actually establish what that means for them.
That's very useful. Just on that, I guess, have you had many, 16 or 17-year-old, are there any kind of, tricky kind of
I
age
find
kind of area?
Under 18, I'll be honest, is probably, it's probably an area that I probably wouldn't be, if they've got a pediatrician that they've been started on puberty blockers or whatever, for me, it makes sense to write this letter. But in our practice, we don't prescribe to under 18, like start patients on hormones under 18. And there's a whole process around even someone who's probably from 18 to 20 in terms of making sure legally that we're doing the right thing by them with their informed consent and they're making the right decision, even though they're an adult. I do feel a little bit like this activity with the gender reform and the document is probably much easier and certainly less concerning. And in itself, if this is the first step in their journey, and we're not talking about going on hormones for a little bit longer and they're young, then I wouldn't find that as confronting. But yeah, certainly for young adults, anyone under 16 or just turned 18, I find that is probably one of those sort of much slower conversations about how do we go about this process with their gender affirming journey. Does that answer your question, Bennie?
Yeah, it does. I don't know whether anyone else got experience to share here, because I can imagine some other doctors may practice a little bit differently, but I guess that is something that you and your practice has, chosen to do, given the all the different elements, which is very important. Can I ask a question, given that not many people are, and I'll just keep going. What is the why did the government highlight sex or gender differently in this context? Is there something that the clinicians need to be aware of when this has been called out specifically?
Well, I guess we'll say we're not asking the doctor or the psychologist to say it's sex or it's gender. We've just the legislations use the term sex or gender together. As to the why, there was much debate on that throughout Parliament. There's no real clear answer other than at some point it became a political decision and it became a drafting decision. When we're drafting legislation, we often draw on other states and territories, and at the time of doing this, WA and New South Wales were the only two that still required a reassignment procedure. And just remembering some jurisdictions use sex, some jurisdictions use gender, and one or two used sex or gender identity in the case of South Australia. And one of the very interesting things with the WA process as it was you would apply to the Gender Reassignment Board for a gender recognition certificate, but then you'd apply to the Registry of Births, Deaths and Marriages to change the sex on your birth certificate with a gender recognition certificate. So it is convoluted. And what I will say is that there is a 3-year review clause in the legislation. So generally we'll review significant changes such as this after 5 years. However, due to the interest in this change, there is a review going to be held after 3 years, and the language used may be one of the things that we'll be looking at, particularly if there's a strong opinion that it should be sex or it should be gender. But yeah, certainly we're not asking the letter to say the person's changing the sex or the person's changing their gender. We're just saying sex or gender.
Can I am I able to bump in from a operational perspective, if you don't
Absolutely.
mind? Just to say anecdotally that it hasn't been raised at all as an issue by people applying in at the registry. No one has challenged staff on why we're using gender and sex interchangeably. And from a recording on a birth certificate perspective, we have a standard template that we use with those descriptors, and it does mean that we can account for everyone in the community who appreciates gender, people who are very adamant that it's just sex and that's it. So it's working well. That's just from my perspective here. Yeah, there really haven't been any issues. The birth certificates come out with sex or gender on there. We're going to be amending our death certificates. Unfortunately, I know that's but that's a realistic part of the process now, that when a person passes away, they will want their recorded sex or gender on their birth certificate to be as such on the death certificate. So yeah, just wanted to say that we actually haven't locally here had any negative feedback or questioning with regard to the use of those terms interchangeably.
Thanks for that. Are there any extra requirements if the patient has committed criminal offences? Does it matter? Is it related? Do they need extra steps?
So criminal offences, no. There's something which Tatijana outlined, where the person has to basically tick a box that says if they're a required declarant. So essentially that's a very specific group of people. So it's high risk, serious offenders, prisoners and detainees, people who are on an early release order, and people, supervised offenders and supervised young offenders. So before their application will be processed, they have to get approval from what's called the supervisory authority for the application. Essentially, that's your Commissioner, Corrective Services, is it the Prisoners Review Board? Anyway, there's a few sort of bodies or people that then just have to approve the application, and it's not really to stand in the person's way. It's just so that they're aware that the application's been made and they can make any changes. There is also the group of reportable offenders. So they don't have to get pre-approval, but if they do change their sex or gender, either through the birth certificate or an acknowledgement document, they have to report that change to the Commissioner for Police.
But in terms of medical practitioners, you're not being asked to kind of look at a person's, criminal history or anything like that in the decision that you make. Your decision's purely a decision about treatment.
That's good to hear. How does the concept of Gillick competence apply in gender-affirming care cases? Gee, I haven't applied my brain into Gillick competence for a while.
Wow, I think that could be a whole seminar on its own.
Yeah, I'm opening this question with 5 minutes ago. So
I don't know how to answer that in that. Look, there have been changes. In some respect, I think we had Reed Calvin, where Gillick competency was almost seen to crown everything, and as long as you were Gillick competent, a minor could consent to what they call stage 2 gender affirming treatment. That wasn't completely reversed, but it was, I guess, toned down a bit by we then had re-imaging, where look, Gillick competence is still very, very relevant, and you can consent to treatment, but only in circumstances where your parents and your medical practitioner all agree. So if there's any dissent, if there's any disagreement, it doesn't matter if you're Gillick competent, the court's going to take over. So I think a lot of people almost thought that was a backward step for trans youth, I guess, who kind of fell within that, probably that category that Mary was talking about, that sort of 16 to 18. So it still has a role to play. But it's secondary to whether your parents and your practitioner are all in agreement. And if they're not, unfortunately, we're still back before the family court getting orders.
That was a very good summary. We didn't need an extra session for that question, so very impressed. Mary, any comment to add there?
No, well, I was going to say exactly that yeah, really got to have that parent involved in that with the young person. So, but it does only need to be one parent, I believe. That's my understanding. Yeah, or assigned. Yeah, see, I don't do under 16. That's why I was very happy, Catherine, for you to answer that question.
Yeah, I think it's actually both parents, because certainly there's cases where one parent will agree and one won't, and in fact, re-imaging was exactly one of those scenarios. If the only disagreement is in relation to whether the patient is Gilead competent, then you can apply to the court simply for a declaration in relation to competency. And if the court says, yep, you're Gilead competent, then that's okay. They can go and they can consent to that treatment. But when there's disagreements about the diagnosis, the treatment, competency, one or any of those all together, yeah, unfortunately, we are back before the court, and we know that can be cumbersome and expensive, and no doubt stressful too for patients who have to go down that route.
We are doing pretty well on time. I don't know whether there's any questions from the audience. Alison, you got something to add?
I have, thank you. I just wanted to raise one kind of issue or circumstances that we've come across a couple of times now, is applicants who are born in WA but are residing overseas and have put an application in with us. But under our legislation, the practitioner who's providing the letter of support needs to be a registered practitioner here in Australia. So I haven't been able to accept the letters that are coming through. We've got one applicant in Scotland at the moment who's mentioned that they have a GP here in WA when they lived here. And I did suggest the possibility of their GP in Scotland perhaps liaising with the GP here in WA, noting that even if they've got, they're undertaking treatment in Scotland, a GP here in WA might be able to assist in providing the letter. So I don't know what the thoughts are on that, but that's the problem we've got. And I feel like for a couple of our applicants, they're hitting a brick wall. They're just, and is it possible for us to be also, referring them? And is there a possibility of, say, a telehealth consult or something like that? I'm not sure. I don't know quite how to resolve that or what kind of advice to give our applicants in those circumstances.
One thing they can do is a telehealth, but they don't get a rebate for it. So you just say you need to book a private consult, no Medicare rebate, with their GP that knew them beforehand and knows of them, and they could do that. But they're going to be billed privately. So whatever the private bill is, they must tell their GP they're overseas. Otherwise, the GP, if they don't put it through privately, just causes some problems with Medicare.
Great, thank you.
We are coming up to the 1 hour mark, so can I just see whether any one on the screen, including a panelist, have any additional comments? Feel free to unmute and speak up. I will just take that as no. So just want to let people know that there are some extra resources at the end of a slide pack. Natalie, I don't know whether you want to just go to the last slide. We're happy to email these if you don't already know. Very useful resources, but I'm sure if you've got any other questions that are not listed here, one of us would be very happy to help, especially the registry. And I would just like to close by thanking all of you for attending, in particular the Department of Justice, the Registry, the Department of Health, Dominion Legal, and also Rural Health West for supporting and facilitating this webinar tonight. I will draw this event to a close. Thank you again, everyone, and have a good evening.
Thanks, Bennie.
Thank you.
Thanks, Bennie.